In our first episode, Dr. Daniel walked us through how HypoCure went from a new concept to a core part of his everyday clinical conversations. We explored the journey from first learning about the procedure to building confidence in offering it to patients, and the key moments that solidified it as a go-to solution in his practice. Today, we're going to take that conversation a step further. And this time, we'll focus on the evidence-based practices that guide each step, from diagnosis to surgical technique. We'll explore the role of X-rays in radiology in accurate diagnosis, the importance of pre- and post-operative physical therapy, how HypoCure compares to other treatment options, and the techniques that can make or break surgical success. Our goal is to help both experienced and newer providers refine their approach and get the best possible outcomes for their patients. My name is Cayenne Flynn, and I'm the Director of Global Sales, and I'm partnering today with Sheridan Geisler, our Sales and Quality Assurance Manager here at Grammatica. We're welcoming Dr. Daniel back again. So let's dive in with Dr. Daniel.
Hi, everyone. How are you?
It's a great day here at Dr. Grammatica, Dr. Daniel. Thanks again for joining us.
Oh, it's my pleasure.
So we wanted to first, chit-chat about X-rays and radiologists and the roles that they are playing. So when you're evaluating patients for potential HypoCure treatment, how important is the role of radiology in confirming the diagnosis?
Well, it's extremely important because it's like I always tell my patients, when you're looking at the skin of the patient, and I'm looking at them and I'm testing, and I'm touching, to feel and see where everything is at. I always tell them, we don't really see the bones, right? So just imagine I'm a pilot in a plane that's trying to land, and there's a lot of fog in front of me, so I cannot see the runway. And because I don't see the runway, what do? I rely on my instruments. And because I am relying on my instruments, it's extremely important because that's what's going to land me correctly. So X-rays is like my instruments on the plane. It tells me where I'm supposed to be, what am I doing, and how am I going to be doing it. This is the investigative portion of the visit, basically, So right now we're just feeling the pulses, feeling the nerves, making sure everything is okay, making sure the reflexes are okay. But then X-rays help us with knowing what's inside, what's cooking on the inside. Is there arthritis? Is there dislocation? Is there derangements? Are there any problems? Are there any coalitions? Are there any other issues that we have to be aware of? Is it truly what we need to look at, what we're trying to accomplish? X-rays is a big guide. And the technique of X-ray is very important.
Very good. That's interesting. So are there like specific X-ray views or angles that you are finding that are the most helpful in identifying the talus-tarsal displacement?
Right. So basically, I always order a bilateral view simply because you want to see a good one against a bad one, right? And most of the time, patients don't really see or feel that there is a bilateral problem. They always see and feel only the one foot that's causing pain, or causing problems. Now, on pediatric, most of the time, it's not pain or discomfort by the patient. Most of the time, it's the grandma or the grandfather or the grandparents, that are actually looking at that child walking and seeing that there's a problem. And so they bring them in so as you can take a look and see exactly what's going on, right? Or they coerce the parents telling them, hey, you need to take this child to the doctor. And so they bring them in. Most of the time, those grandparents are in with the visit. So what we do is we try and do those x-rays simply because of that also. But to answer your question, which views? Usually you want to do weight-bearing pictures because you want to see the biomechanics. You're going to see the physics. This is a physics issue. It's not a chemistry issue. There are two avenues that we can go wrong. There is physics and there is chemistry, and these are basic core sciences, We are looking at the physics of it, what's going on physically. And for that, we need weight-bearing pictures because that's when you see the maximum amount of information. That's when you see the angulations. That's when you see the derangements. That's when you see any problems with the way the patient is standing. And I always emphasize on the technician to put them in proper positioning. Even though you ask for an AP, which is anterior posterior view, lateral, which is a side view, lateral oblique, medial oblique, all these views that you're getting of the feet and ankles, you really want to make sure that the technician is doing a good job. I sometimes get the patient coming in from a certain hospital and they haven't been positioned correctly. And then I see that on x-ray right away. And I can find out that they have done a bad or a poor job in the placement of the patient. And then you can tell there's a problem here. And you talk back to the radiology and say, hey, please, can you put them in a good position? Now, if you have those things at your office, it's extremely important that you train your staff as to how to do those x-rays properly. And there's a ton of stuff out there about how to do those things properly. Weight-bearing pictures of the feet.
Okay, great. So for surgeons that are newer to this space, what would you say are the top 3 things that you should be looking for in those x-rays?
So again, once you do the actual pictures and you have them on your computer, nowadays it's all computerized. I'm so old. I used to put them in that little bin and you just chemicals and put them up to dry with the peg and as if you're doing your laundry. Long time ago. So anyway, nowadays you just pop them on the screen. You can angle, you can mangle, you can do whatever the heck you want to do with them, and it's so fun. So the major thing is that you actually understand what the talus is doing. The talus is a free motion kind of a bone. For me to move my finger, there's a tendon here that actually fires up with a muscle that actually tells my finger to move. The brain gives the information down here, the nerve gives the information to the tendon moves the finger. And there's another one over here that makes it go up again. Oh, well, that's how our skeletal structure does the work that we do. It is a function of muscles trying to move those bones. The talus have no tendon. It was designed that way. Whoever created us was very, very smart. And they created us so as we can actually walk in nature beautifully and also to adapt to nature. So if there's a stone, your foot kind of goes over the stone nicely, if there's a climb downstairs, whatever. Humans thought, oh, we're much smarter. Let's make everything flat. We'll walk on flat surfaces. Well, again, we were not designed for a flat surface. So the talus, because it is an adaptable bone, it does not have any tendons. Because it doesn't have any tendons, it relies on the tendons around it to accommodate it later. So it actually accommodates the gravity as you come down to the floor, and it puts the forefoot, especially the medial portion of the forefoot, in the position where it should be. And then it relies on the tendons in front of it and behind it to control the scenario. So if the scenario is no good and you're always flattening, it's causing problems all the time, that talus is actually dislocating all the time, it stays there and it causes further issues. And then you have all kinds of other issues. So when we're looking at things, we're looking at the interplay between the calcaneus, the talus, the navicular, and the cuboid. Those are the biggest ones.
When you're looking at an x-ray, that's what you're looking at, right?
That's what I'm looking at. I'm looking to see what's the interplay, what's happening to those bones, Now, on a lateral view, that gives me more information about what we call the first ray. The first ray is defined as the medial cuneiform, which is the inside bone of the foot, the long bone of the big toe, which is basically the metatarsal, and then the phalanges, which is the toes, okay? So the first ray is that combination of all of those bones, which is the cuneiform, medial cuneiform, the first metatarsal, proximal phalanx, distal phalanx of the hallux, which is the big toe. Now that's very important. Why? Because when we were created, we started to be in a way that it was like this, and then we went like this, and then became like this, and then we had a foot. Well, that thing here, that's the Lisfranc ligament that's holding it together, plus the peroneus longus tendon. those two are the ones that are actually pulling that first ray where it should be. Nevertheless, they're very weak compared to the anterior tibial, which is on the top of the foot where it's actually pulling it up direct. So we end up that the anterior tibial has to counter also the tender Achilles, and it causes problems that way. So you have many, many things when you're looking at things, okay? So you have to understand your numbers too. You know, what is a good number? What's a bad number? Where are you going with us? And so on and so forth. Okay? Does that explain it a little bit?
So I guess to kind of clarify what you were saying is to look at the different pieces. So the first ray specifically, when you're in the X-ray, to see what that's looking like, and then what was the second top thing that you would say. So that's the first one, right?
And also the interplay between the talus and the calcaneus. What's the numbers there? You know, what is the talus doing to the ground? What's the calcaneus doing to the ground? What's happening there? And also to see what we call an angle on the AP. It's called the total contact or coverage, the talus coverage angle, TCA, where basically how is the talus doing compared to the navicular? What is it doing? Is it covered too much? Not covered too much? What is it doing? All of those have numbers to them, and they all have, that gives you information as to what the talus is trying to do.
Got it. So, how closely would you say that you work with radiologists during that diagnostic phase? I mean, typically, I know you're the ones that looking at the x-rays, but do you find it beneficial to review images together, or do you prefer to do it on your own?
Again, if you have the instrumentation at your office, you're doing it, right?
Yeah.
Okay. If you're doing it through a hospital or a radiology center, you'll get a report, right? Well, most of the time, radiologists are seeing like 200 pictures a day or 200 things a day from all over the body, right? And they really don't have much time to tell you every little detail, you know? I always, almost 0.9% of the time, I'm over reading the x-rays, you know? So I'm actually, they have the report, but then I overread my report. I put in my report as well.
Sure.
And my report have the angles most of the time because they never do angles for you. They just say slight so and so, some so and so, and please correlate clinically, so they can get out of it kind of a thing, And that's what they're doing most of it. Nothing against radiologists. They're very good people and they know what we want. But if you have one that's in tune with you, which means if you have somebody who's really close to you and you know them very much, you can actually get them on the phone and say, hey, can you add those things in there and get me on the report or something? But I usually don't. I usually just say, hey, except if I'm really seeing something different and something that's unique and whatever, then I would call. I don't want to bother them too much. So I usually do my own report and I attach that into my note,
Yeah.
as to what I saw. And sometimes what I've been doing recently within the last few years is actually taking pictures of the angle just to keep it on my report because those come in from another entity, from a third party, So it's not actually in my database. And so I usually like to keep something in my database. So I usually take pictures and put them in my database just to keep track as to what it looked like at the time when I saw it.
Sure.
Because then later you can just say, okay, well, this is what it looked like. These are the angles that I saw. Now it looks like this. This is what the angles look like now. And
Right.
that's what you're looking at most of the time.
Yeah, it's the angles. You're comparing what it was to what it is now after correction, right?
Exactly.
And those angles are just key in determining what is the best, not only the best size, right?
Yeah,
Like if there's too much, then the angle's not going to
exactly.
be good.
And radiology is actually very, very crucial during surgery too.
Mm-hmm.
So, and you try to do those angles that you had before when you were doing the original pictures in surgery as well. So you try and keep that in your perspective at all times as you are doing surgery, because HyProCure is a radiological thing that you can do. It's not something that you are seeing most of the time. It's your anatomy knowledge plus the radiographs that you're looking at,
Mm-hmm.
It can take you 7 minutes to finish, or it can take you an hour to finish, depending on your skill set. and your skill level.
Mhm.
But if you're good at it and you've done it many, many times, it's a 8-minute procedure. You're done. It's a very, very fast procedure. Um, overseas we do them all the time. We done like 10 of them in one day, one time. It's a very fast procedure. It's a extremely fast, and you're changing lives with it. So it's a very nice procedure. Nevertheless, I kind of veered off. I'm sorry. Let's go back to radiology.
Well, let's actually kind of change things up a little bit, talking more about pre-op and post-op PT. Our last episode, you really brought to the forefront how PT really helps prepare your patients for this MIS procedure. So, how often are you relying on post-op imaging to track the recovery? What kind of changes are you expecting to see over time?
Okay. So if you are versed in and we're talking about HypoCure, right? I mean, or
Yes.
whichever procedure, it doesn't matter. Originally, I usually just tell most all my patients, again, to actually go and get a PT eval. Why is that? Because you want to have that to tell you which muscle is working, which muscle is not working, what's happening, what the PT is going to try and do. It's extremely important that you know that information before surgery, as well as see what they can do for the patient before you even touch them surgically, no matter what the surgery is. Now, for a HypoCure, you really want to concentrate on two major ones, and that's the posterior tibial tendon and the peroneus longus tendon. Those are the major ones, okay? Nevertheless, you don't want to lose sight of the tendon Achilles being tight, or the anterior tibial not functioning well, or the peroneus brevis, or any other tendon that's coming into the foot causing issues. So you have to be, again, well versed in all of them, but the major ones are the posterior tibial and the peroneus longus, because they actually hang on to the foot as if they're the reins of a horse's head. One turns to the right, one turns to the left. You want to be in the proper positioning. So you want to, put that horse's head in the proper positioning,
Right.
because that talus has no tendon. So it relies on all the other tendons to put it where it should be back in place. And so PT is crucial as well in our prelim to make sure that we have a good result. We do sometimes about 6 weeks, 4 weeks, depends on the patient, of preliminary physical therapy to see if the physical therapy is going to help with this or no. We put them in good arch supports, high top shoes to control the ankle rotation. We do all that just to make sure that this is going to work, yes or no. Because if it works, hey, fine. They can do that all the time. It's like having eyeglasses. You put them on, work. But if it doesn't work, that's when you are now saying, okay, well, we tried, it's not working. Let's see what we can do other than that. So we do X-rays repetitively during the course. So we do one, and 6 weeks later we do another one after, see what's going on. Is there a change? Yes, no. There's no change, then you move on to the next step, right? So that's important. Does that explain it?
What timeline do you actually do imaging? Is it 10 days after, 4 days after? What does that look like in your typical process?
Okay, after surgery or after therapy?
Post-op.
So you're doing it on the table. You're seeing it on the table, right? So you're
Yep.
doing a final picture of your final result on the table before you even get the patient out.
Right.
Okay. And we have a certain technique that we do whereby you provide those nice, beautiful plates that come with the actual set. And that metallic plate acts like as if it's my ground. And I actually push the patient up and load them up as we're doing the X-ray. If I may plug into my YouTube channel, but you're welcome to look into my YouTube channel, check out
Yeah, you've got a good
my
video.
videos. Anyway, so basically what I'm trying to say is you have the final picture is right after surgery, right after. Okay, that's now that I said that. You also do another one in about 6 weeks. Now they're doing 4 weeks, depending on what you want, your comfort level. Now, if you have an injury right after surgery, you've got to do another X-ray, right? So, you have to take it as they come. But nevertheless, usually it's a good idea to do another one in about 4 to 6 weeks when the patient is actually starting to weight bear. and actually being able to get up on their foot, and do something.
Yep.
So now you want to see an X-ray to say, okay, well, this is what it looked like before, this is what it looked like after, and then maybe another one in 3 months, and then 6 months, and a year. And that's how I usually do it. Now, after a year, I usually tell my patients on a yearly basis, if you can come back just for us to see if there's any problem, if we have to. And then usually after a couple of years, we let them be and they can live their life,
Okay.
But that's how my protocol.
Great.
Okay.
All right.
Now, given that I just said that, we vary according to the situation, right?
Yep.
So you have to take whatever comes in the door and manage it because
Okay.
you're the one who's managing things, okay? Those are things for you to learn, but it doesn't mean that it's etched in stone. Situations come up. So you have to deal with the situation as they come in.
Of course.
What drove you? Last time we talked, you mentioned how one of your patients had just gotten, the HyProCure put in, went to PT and dislodged it, right? They were doing something in PT that dislodged it and you had to look at it again. So, how do you work with physical therapists when you're creating a plan for your patients that is specific to HyProCure, right? I'm sure they have their own protocols, physical therapists do. But do you provide specific protocols for folks that have had HyProCure?
Okay. So what I usually tell my physical therapist is that I am looking, before surgery, I'm looking for peroneus longus and posterior. So they already know this patient, right?
Okay.
The patient went to them. But then after surgery, I also provide my op note, okay? And I tell them that this is the op note. That's what I did. And please don't do inversion eversion for right now. Just go up and down with them, and basically dorsiflexion, plantarflexion more so than anything else. Now, sometimes you don't do that. Busy practice, whatever, and you don't send this exactly what it is, and then they do balance board or they do balance beam or something like that. And it's like, oh my God, and the patient twists and goes into inversion, eversion. They come to you and they're like, oh, this is what happened. And then you end up having issues. That happens when you don't have a communication already established from before with the physical therapist and or they don't know you. Like they had to go out of town to go somewhere else, and or they come to you from out of town, and the physical therapist in their area doesn't know you and doesn't know what the heck is HypoCure or what it does, and they don't have the time to look and find out more about it, and then they have an issue, and then we have a problem. And I've had few like this, you learn from a lot of things in life, and I've had my fair share of learning. So
So
everybody
really
does.
what you're saying is that you have a specific physical therapist or a whole office of physical therapists that you really have a connection with, that they know your protocol, they know what to expect from you, as well as you know what to expect from them, right? You guys work together as a cohesive unit to get to the goal of ensuring that this is great for the patient.
Again, I work out of many, many places. I don't know if you
Mhm.
know that, but I mean, I work out of 4 different locations almost in the United States. And then I work also overseas with a couple of other countries, at least. And so in other countries, it's different than here. Here, it's kind of hard because there's like 4 different locations, and each hospital has their own PT and so on and so forth. And then there's the individual PTs that are on their own and other than the hospital. So you end up really trying to tell the PT with your wording, please do blah, 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 evaluate, treat patient for ankle instability. Please look at the up note. We don't need inversion, eversion kind of thing. If you have questions, please call, and you give them their cell number. I do that at least, so as they can reach out to you if they have a question, right? And I've had a few call and say, hey, we've never heard of this. What is this? Can you direct us? And we'll direct them, right? But then we have also, like overseas, when I go overseas to the country of Georgia, in Tbilisi, even in Kutaisi and Batumi, we have specific groups of physical therapists that have worked with us so much that they know exactly what I want and exactly what I need. And they know when I say I need peroneus longus exercises, they target that peroneus like crazy and they make it happen. And I've seen elevated first rays from 6 millimeters drop down to 2 or less just by physical therapy action. And that's normally a surgical procedure at that point. So that's what I'm saying. So you can actually really have a very good physical therapy department that helps you out, that
Mhm.
can give you that support. The work that you do is just you're changing things, but then you have to rely on all the other people around you
Uh,
to make it a very beautiful job. And if you don't have that support, sometimes it makes you a little bit lacking in the good results that you may be able to get. And that's a problem sometimes, and it causes some issues with the HyperCure either dislodging or misaligning or getting out or something like that. And we've seen some of these come out, and it's like, what do you do? Well, you handle it, right? So whatever
Right.
comes in the door, you have to handle it. You're the one who's managing, right? So you manage it. And we'll talk about that some other time. But what I'm saying is there are things that you have to manage. So you basically do things ahead of time, because if they ever come in, you already managed the situation, not risk as much as just basically managing, you know.
Mhm.
And it's a lot of work. I know. A lot of people say, "Oh my God, I don't have time for all that." I understand that. And if you have a good physical therapist that you like, by all means, get to befriend them and be their buddy, because they're gonna rely on them like crazy,
Yeah.
So yeah, and I've had several of them that we do business all the time with them, and we know them, they know us, and we send them all the work that we have in the area, because they're the people that work on it, and they know what we want, whether it's electrical stimulation, whether it's exercising, whether it's stretching, strengthening, whatever it is that we're trying to do.
I mean, you're all working together for one outcome.
Exactly. I mean, I'm not an island. I'm a conglomerate of a lot of people that actually have helped
Yeah.
with those outcomes,
Yeah.
whether they're bad or good, be it. You just manage the orchestra basically, that's what it is. You're managing all this orchestra of people,
Right.
and each one of them is doing the job that they need to do to help you get a good result. The bottom line is getting a good result for the patient. The patient is happy, the patient is doing back their ADLs, and they're doing everyday activities with no issue. And that's the bottom line,
Yes.
That's where we need to reach. And there have been studies on HyperCure, I have to plug that in, that it's been 90+% good result, right? Over 5 years at least. And now
Uh-huh.
we're going on to 10 years for the next one that's coming up.
Hmm.
So hopefully we will have good reports on those too. We'll see what happens.
Yeah. Yeah. We're excited. So kind of transitioning into, other options versus hypercare, right? Patients come in and see you, and sometimes hypercare might not always be the best choice for that particular patient, right? So in that same vein, in which cases would you recommend orthotics as a first line option before they would consider hypercare?
Okay, so so you have two different kind of patients. You have a patient that come in, never had anything done, and you've had patients that come in that have tried everything under the sun, all right? So the patient that have come in and actually tried everything under the sun, you pitch in the hypercure right away, because
Right.
that's the next option, right? But you also tell them that, hey, maybe we need to do a little bit of muscle stimulation to get things rolling, to prep those muscles for the hypercure, because the hypercure puts the clearance where it needs to be, but then the forces are still there.
Right.
The abnormal forces are still there. So we need to reduce that somehow. And so you always want to manage that somehow with the patient. It's the way you talk to them a little bit too. Now there are patients that are just, and there are patients that are like, wow, yes, I like this.
Yeah.
Have the
A
spectrum, right?
variation.
Right,
Yeah.
right. So you also have to read the patient and see. And sometimes I'm reading those patients, I'm saying, hmm, should I do this now? Yes or no. And if
Hmm.
you have a doubt, don't do it. I'm telling you right now. Okay? Do something else, because I've fallen in that pitfall before. So don't do it if you don't want to, or if even though they need it. It's
Yeah.
patient kind
Yeah.
of gives you that vibe sometimes.
Yeah.
But there are patients who come in for ingrown toenails,
Huh.
especially kids. They're having it because of biomechanical issue,
Yeah.
in the way the hallux is, it's not staying straight, it's rotating, so it's pushing the side of the corner here against them, not because they actually did anything. It's just because of the way the varus deformity and the valgus deformity is causing the problem. And then you are like, huh, I'm the doctor, right? So am I supposed to tell the parent that, hey, there's a problem, yes or no? And the minute I open my mouth and start saying, they have some ankle problems, they have very weak ankles. Doc? Yes, he does. He does trip a lot. He does have issues with me telling him, hey, to do this, and then they say they cannot do it because they have pain or they have discomfort or whatever,
Yeah.
and they're like flabbergasted that you actually picked it up. I told them.
Yeah.
Wow.
My opinion is, you're a doctor. You have the responsibility of saying everything you see
Yes.
on that patient.
Right.
You cannot not say something.
Right.
You gotta say it.
Yeah.
It is up to them whether they take it or not.
Right.
You just pull it out. Say, hey, I'm seeing some problem with his cleat as he's standing. Is there an issue? Yes, no. If there's no issues, that's fine. Don't do anything, whatever. If there is an issue and they're coming in for something else, okay, like wart or ingrown toenail or aptitude, whatever,
Mm-hmm.
and you're seeing this biomechanical issue in front of you, start with some arch support. You know what I mean? Don't
Mhm.
hit it hard, in my opinion. And
Okay.
it's not like arch supports are bad. They're good. They're not bad at all.
Yeah.
They're the external fixation or the external treatment of that talus becoming a problem, right? Do we need arch supports afterwards? In some cases, yes. After surgery, you need arch supports,
Mm-hmm.
even though you put a HyProCure in, because you have such weak muscles.
I was just gonna say it's because of the weak muscles
Weak muscles
around.
are a problem.
Yeah.
And if you don't have also Ehlers-Danlos syndrome problem, whereby you have weak ligaments, not only weak muscles, you have good muscles. You have such good muscles, and they show me, hey, I have good muscles. What are you talking about? Well, you know what? You have a little bit of Ehlers-Danlos. Can you put yourself in a box? Yeah, I've done that before. Yeah, well, again, you have weak ligament, and the ligament it's a structure whereby the bone, ligament, and tendon that are working, and if any one of them is not doing the job, deranged bones, weak ligaments, weak tendons, we have an issue.
Yeah.
You've got to address all three, and the nerves and everything else. Now everybody's going like, oh yeah, he's missing something. I understand. What I'm trying to say is those are like major things I'm talking about, not details. Okay, each
Right.
patient have to look at the patient. Make sense?
Right. Yes. So, how would you say HyperCure compares to other minimally invasive surgeries and even full reconstruction in terms of recovery risks and honestly patient satisfaction?
So I do open treatments, which means I do triple arthrodesis. I do all these things, right?
Yep. Right.
I do Evans, I do Cottons, I do all these things. Don't take me wrong, okay? But the majority of my work is HypoCure, simply because it is very minimally invasive, number one. Number two, um, it is reversible, which means I can take out the implant and go back to where I was. And all I found my patients me 6 months to make that stay where it's at, to make
Mhm.
the structure stay where it's at. So as you can train those tendons to stay where they're at. And that's what happens most of the time. If I take it out after 6 months, I have some kind of a cohesiveness of the tissue that it doesn't go back to where it was before the surgery. I'd rather they be a year, let's say, but if they can hold on for 6 months, and then I support them, then I put on, heart supports, high top shoes, control everything. We monitor all the time, what's going on, what's happening. Majority of my work is HypoCure on these on this particular set of patients. Okay, if there's arthritis, you got to think, okay, is the HypoCure gonna be my beneficial thing? If there is coalition, do we want to do HypoCure? Do we want to venture that? Well, how is the patient gonna help me out? Because I will do the work, but then the patient is with that unit all the time.
Right. They need to do the work
Yeah.
They
too on
go
their
home,
end.
right? They go home and they have it in their foot. You're not controlling that. So God only knows what happened. And then they come with problems and then asking them, hey, did you do anything? Anything wrong? What did you do? Oh, and they don't never tell you. And then if they have somebody with them, they'll say, don't you remember you fell on this? Or don't you remember you
Oh.
kicked this? Or don't you remember? And then you get the whole story if somebody's there. 'Cause most of the time you don't get the story. And you
Yeah.
have to be a detective to find out what the heck happened,
Yeah.
you
That's a
know?
good question.
And that's important too, because most of the time that what happened is not fully there.
Yeah.
Did that
Yeah.
answer the question?
Yeah, for the most part, I think that what you're saying is if I'm understanding correctly, is HyProCure compared to other MIS and full reconstruction, it has, a better recovery time, less risk, and higher patient satisfaction.
Correct. So I'm gonna actually talk about HyperCure and the other units that are out there. I'm not gonna mention names, okay? But let's let's say we'll call it. There is one called the Italian. How's that? The Italian one. Okay. The Italian implant has to go in the bone. All right.
Right.
So you have to actually drill into the bone to put that unit in the bone. All right. And I've had to remove a few. I've had to remove some HypoCure too. Don't take me wrong. Okay. But what I'm trying to say is it is something that people are doing, especially in Europe and overseas.
Uh-huh.
But all I caution you is whenever I remove one of those implants, I let the patient stay without nothing for at least a year and then revisit them with a hypo. Why?
Okay.
Because they actually made a gouge where I need to go in the bone.
Sure.
And that causes a problem for us. So we usually don't touch it. We do CTs, make sure everything's okay before we do anything else. Okay? Nevertheless. So I have seen doctors though who have done the Italian unit and they don't like it. I don't do the Italian, so I don't have an experience in that, but I have friends who did. And they always send me those patients saying, please take that out and put your unit in. And they already have explained that to the patient. You know what I mean? So it's kind of like they already know that this is not a good unit and they're working on it. Nothing against the Italian. It does do the job on certain patients, but not everybody again. Now, also the other one that they started with long, long time ago that's not ergonomic, that actually goes into the sinus canalis portion, that locks up the joint. And again, you have to take these out and put one that's more ergonomic. Also, the other thing is the triple arthrodesis. You mentioned open or whatever. The other option is either double arthrodesis or triple arthrodesis or mono arthrodesis, whatever you want to try to fixate the issue, whether it's a TN fusion, CC fusion, the whole thing fusion. All of those are good results, especially on those sets of patients that you need to do with them. You can always convert to those things. You can put the HypoCure in first and buy them some time because some of these patients are so severe, but they're young. You really want to take out those joints,
Right.
Right.
And I call it a joint destructive procedure when you're going in there and doing a triple arthrodesis. Whereas HypoCure is a joint salvaging procedure, which means it is not going to destroy a joint. Why destroy a joint when you don't need to?
Right.
Try it out first. See how that works out. Because most of the time, with a few, also, you can also do an adjunctive procedure to the HypoCure to make it even more of
Successful.
a successful operation, like posterior tibial tendon fixation, like cotton procedures, like AIS, anterior impingement syndrome removal, like gastric releasing. All of those things help the implant do the job it needs to do. And you have to assess that, make sure that you may want to do those during the same procedure of the HypoCure and or thereafter, and make sure you tell the patient that there is a possibility that these things are going to be happening for you to know. We're going to assess this, find out whether you need those procedures afterwards, yes or no. And the patient's thinking, oh, am I going to have like 3 or 4 procedures? I'm like, yeah, possible. I don't know.
Right.
Let's see what happens. Let's put it in. Let's see what happens. Minimally invasive, very much a good procedure. And also you can actually take it out with no harm done. Whereas the other procedures, I cannot do that. Once I do them, it's done.
Yeah.
I've done the damage. So I don't want to damage anything if I don't need to. Now did that answer?
Dr. Daniel, we wanted to ask about some of the different techniques that you really rely on when it comes to HypoCure. And as you've been doing a lot of training and mentoring, are you seeing some pretty common technical mistakes that surgeons make when placing the HypoCure? Like, what should they be avoiding? Could you give them maybe some best practices when it comes to that?
Sure. Well, the biggest issue is the interosseous ligament. That's between the talus and the calcaneus. Okay? That's basically coming in from the top of the talus, going down to the calcaneus, and it's hooking up between the two. All right? That interosseous ligament has been damaged many, many times over. So it's a thick unit. It's got several aspects to it. And I train that on that I train. And I tell them, hey, you have to think visually where it looks like, what it looks like, and I sometimes stop the surgery and just explain it to them on the table, just to show them exactly where it's at, especially on the patient. We sometimes throw it out to show, hey, this is what it looks like, this is where you're going. Because you're not seeing, you're feeling, but you're not seeing.
Right.
So if you don't cut the interosseous ligament completely, you will have a rubber band effect,
Okay.
whereby the implant hits that ligament and it rubber bands back out.
Mm.
Okay? So it hits the ligament and then it bounces back, and you can feel that with your sizer.
Okay. Good.
As you're putting in the sizer, you feel that there is some kind of a rubber band effect going on. That means you haven't cut it completely. You gotta cut it completely. And don't just keep cutting, That's gonna cause scarring like crazy. And you're gonna have issues. Don't just keep cutting this thing. Just do it one swipe. Think about it where you're going. Swipe anterior, swipe central, swipe posterior, and always go with a J action around because it's going upwards toward the medial aspect. Just don't hit the posterior tibial tendon and cut that. Be careful what you're doing. You need training. By all means, let us know so as we can train you out. It's extremely important. We want you to have a good result. Extremely important that you get trained properly. Did that answer your question? So that's
Yeah,
one thing.
I think you've answered like 3 different questions all at once.
Yeah.
But that
Answer, I was going to ask you like what are maybe like some non-negotiables, but it sounds like you just answer that where you're cutting this way, that way, up
yeah.
to the top, yeah, so
The
that
other
there's not that rubber band effect.
Right. The other thing is if you look at the foot from a head-on view kind of a thing, as you're sitting on the table, you're doing a AP ankle,
Okay.
So the foot is right at you. I cannot put it, but you just imagine it's coming right at you. Okay. So the foot is in front of me right here. I'm doing an AP ankle. I'm seeing the ankle, but at the same time, you see the talus and the calcaneus on the view. Okay. And as you're putting in the HypoCure goes in. You can see the HypoCure or the sizers. You can see the sizers jump a small little ledge on the calcaneus. If that, you can actually feel it. Okay, you can feel it going through the skin. You can feel it going through the deep fascia, and then you can feel it jump through that ledge on the calcaneus. And if it does not feel that you actually jump that ledge, the implant is not in place. You gotta feel that boom, boom kind of thing. It's
Get it all the way in
bumps, right? And you can see it on X-ray. Now, don't get it all the way in there and shove it through the sinus canalis. We don't want to go there. We want to be right outside of that area, but in that little ledge of the calcaneus, because that's going to stop it from falling out.
Very good. I like that little curl that you just gave us. That's very key, that it goes bump bump and then it's in there.
Right.
I like hearing that. Good.
Right. You actually can feel it.
Yeah.
You feel that. And sometimes you can hear it. It's audible,
Really?
Yeah. Yeah. And sometimes the people around you, in the room, they're like, what did you just do? If they're curious, and you'll say, oh yeah, I just placed it in place.
Nice.
And then you take an X-ray and it's right there where you need it.
It's great.
The training.
Yeah. Because there's those little nuances. I think we spoke about this before, where it's more of a feeling because you can't see, right?
It is all relying on that X-ray, on the X-ray guide. X-ray is extremely important in the surgery. So you need to see it in your brain, on your screen.
Yeah.
You need to feel it to see where it's at.
Right.
Okay.
If you could give one piece of advice to a surgeon that is refining their HyProCure technique, what would it be?
Make sure you cut the ligament. Make sure you do the bump, and make sure you take X-rays afterwards that are proper.
Yeah.
So what I usually do is I do an AP foot, 15 degree, table straight. I also do a AP ankle. I also do an axial implant X-ray,
Mhm.
whereby I see down at the barrel of the implant, because you can see it, that it's not touching anything, and that's for documentation purposes. So you can
Mhm.
actually document it. Hey, it's not touching anything. Those are three major ones that I do. There are other things as well, but I mean, this is the most major thing that you can do. Okay, so make sure you cut the ligament properly. Make sure it goes through, that it's actually sitting where it needs to be, and the alignment of it is correct. And once you see it on X-ray, that's aligned perfectly. You see a beautiful design for it. The simulation is good. The fibula complex is good. Everything is good. You're done. But you have to make sure you see all that. And those are all X-ray guided, film guided. That
Good.
help a
Yeah.
lot?
Yeah, I think that's fantastic. That's really what we want to be able to share with everybody today. So,
Yeah. We have
Dr. Daniel,
more
thank
that we
you.
need to discuss, but I mean, a little bit at a time.
Yeah, oh, it's good. Well, thank you again for another fantastic masterclass. We really were able to connect the dots from diagnosis all the way to technique and how to get the right images. That's so, so important. Make sure that that is in the right placement, how to prep and protect the patients with, really partnering really well with your PT. And then HypoCure, the fit versus like what are some of those other different options that are out there in the market. And then the technical choices that drive really the long-term success that Gramatica and HypoCure are really starting to recognize through all the different studies that we have. And we just have a great one that just came out here in 2025. So we're really, really excited about the path that Gramatica and HypoCure are going down.
I agree.
So we do have one more episode with Dr. Daniel. So next time we're going to get practical about the business side of things. So why it pays to offer HypoCure. So Dr. Daniel, think about that. We're going to break down some ROI and margins, and then realistic, like the time allotment in clinics and in the OR, and how to get reimbursement verbiage, that all of that good stuff. And Gramatica been working very, very closely with the AMA, and we're hoping for some good news coming here
Yeah, I
shortly
like that. I like that
in the
very much.
fall.
Yeah,
So
yeah. We're hoping.
next
Yep.
month, yeah, we should have some great news here.
Yep.
Yeah,
So
yeah. I'd
yeah.
like to also bring maybe a couple of other docs on board to, hear what they have to say.
Yeah.
Yeah.
Awesome. Yep. And I think we're trying to expand out this podcast series and giving a voice to some other master surgeons like yourself. But we
Right.
really appreciate you working with us on this first series. So it's
Well,
been
appreciate it.
pretty
Thank you.
fantastic.
It's my pleasure.
Yes. So please make sure you subscribe so you don't miss any of the next episode, and also send your questions for Dr. Daniel. And check the show notes for resources from today's episode. Now I hope you take what you learned and apply it to your very next case and keep these patients moving forward. We'll see you in the next episode.
All right. Take care.
Sounds
Thank you.
wonderful.
Thanks, Dr. Daniel.
Thanks, everybody.
Bye.
Bye.
Bye.